All right. Good morning, everybody. Welcome to the Coloplast Symposium here at Wounds Canada. My name is Christopher Hoffman. I'm a senior medical specialist working for Coloplast in Denmark, in the headquarters. And I am delighted to be here together with you today and the speakers, of course. As you can see, you have probably received a copy of the wound care pathway and also some colored cards. And I'll come back to what you're going to use them for in a minute, but you will be asked to vote. Then if time allows, then we plan to have like a Q&A session for the speakers afterwards. But we think we can have time for that. Otherwise, both David and Melody are here during after the symposium. Okay, so why are we here today? Well, we are here because we want to address a global challenge. And what we mean with this global challenge is something that we will be discussing during the symposium. And it's going to be very interesting to see how you reflect upon what we see as the global challenge. But we're also here to introduce to you a potential solution to this challenge. And that is the wound care pathway, your 5-step guide to wound healing. I'd also like to say very much welcome to our speakers today. We have Melody Yaceyko, who's a nurse consultant from Alberta in Canada. And we have Dr. David Keast, who is the medical director of the Parkwood Institute in London, Ontario. And I'm very happy and thrilled to have you both here today. Of course, there is some disclosure as well. All right, so we're going to start with the challenge now. And looking at the challenge, if we look at when it comes to wounds and patients, it has a huge impact and burden on patients' lives. We also know that many wounds are not healed within a year, and we know that up to 20% can actually have wounds up to 5 years. So there's no doubt, that's why we are all here today as well, to talk about how we can make their lives better when living with wounds. But today we're going to put another perspective to this. We're going to look at the healthcare professional perspective. And what you're going to do now is you're going to meet Daisy. Now, Daisy is a nurse. She is seen as a non-specialist in wound care. She works in a community in Denmark. And we asked her one question. What are the main challenges that you face when managing wounds in your community? So this is what Daisy has to say.
Jamen, jeg hedder Daisy, og jeg er sygeplejerske i Furesø Kommune. Jeg er det, man kalder udkørende sygeplejerske, basissygeplejerske, hvor jeg blandt andet laver sårpleje og alle mulige andre ting. Alt, hvad man kan blive udskrevet med fra hospitalerne, det laver vi i eget hjem. Og jeg har sådan godt og vel mellem 5 og 10 patienter om dagen, så det kan være sådan cirka 50 stykker om ugen. Jeg har faktisk ikke nogen uddannelse inden for sorg andet end hvad jeg er kommet igennem. Altså man kan sige basis i en sygeplejerskeuddannelse, det er at man skal lære noget om sorg blandt andet. Men jeg har ikke nogen speciel uddannelse inden for det. Mine største udfordringer, når jeg kommer ud til nogle patienter med sorg, det er at når såret ikke vil helt op sådan som det skal, så kan jeg godt blive i tvivl om hvad jeg skal bruge, hvad jeg skal gøre. Og ellers så er det nogle af de her ydre faktorer, hvordan vi kan forebygge sorg, der godt nogle gange kan. Vi har selvfølgelig nogle basis ting, som noget med sko, der ikke klemmer, men ellers så er det de ting, der er min største udfordring. Da jeg startede herude, der synes jeg, det kunne være ret frustrerende at komme ud til nogle af alle de her sorg, fordi jeg ikke havde så meget med i bagagen. Det er jo kun sådan basis viden, vi får fra sygeplejerskeuddannelsen. Men det er noget andet at komme ud og se de her forskellige sorg, og hvornår skal jeg putte det her på, hvornår skal jeg putte noget andet på, hvornår må jeg skære i såret, ikke mindst. Så her, der savner man måske at have lært noget mere, og det kunne være rart at have noget, man kunne måske bedre slå op i, så man vidste, hvad kan man gøre.
So this is Daisy. really talking into her reality when managing wounds today. Now, David, when you listen to Desi, what's she telling us?
Well, I think healthcare workers throughout Canada can feel very much related to what Daisy has to say. We remember that healthcare is, in terms of wound care, is primarily delivered through home and community care. And this is this burden of wounds in the home and community care represents about 50% of their burden often. And they feel cast adrift. They often are sent into work with very little education. This leads to a real feeling of uncertainty. What do I do now? What do I do next? I wish I knew better. I think this lack of education is one of the key themes that we see among healthcare workers, especially these days.
Yeah. Thanks, David. Melody, what are your reflections when listening to Daisy?
Yeah, when I pause and really think about how Daisy is expressing her feelings about shouldering the responsibility, her professional obligation to care for patients with wounds and feeling ill-equipped to do so, it's pretty heartbreaking. I think most of the participants here today would probably agree with me in my perspective that these knowledge gaps exist, and it's an uncomfortable reality that the lack of purposeful, standardized, evidence-based wound care education, it's harmful. It wastes products and therapies, it wastes time, and in many cases results in devastating wound care outcomes for clients.
Thank you, Melody. Yeah, so there's something here about lack of education and frustration for sure. Now we're going to listen to yet another perspective. So we are in the same community in Denmark. We're going to listen to Dorte, and she's a wound care specialist. So you're going to listen to her, and we asked her the same question, what her main challenges are.
Jeg hedder Dorte, og jeg er sovsygeplejerske her i Furesø Kommune, og har været her i 22 år, så det er stabil arbejdskraft. Min hverdag består af at behandle sår, både direkte, og det består selvfølgelig også af at undervise, oplære nyt personale. Jeg har tilsyn på vores plejecentre og bosteder. Så er jeg i vores sygeplejeklinik nogle dage om ugen, og så resten af tiden er jeg så også ude hos dem, som man kan sige trænger mest ude i hjemmene. Altså 85% af det, jeg laver, 90% af det, jeg laver, det er sårbehandling. De største udfordringer, det er at få viden nok ud til personalet, det vil jeg sige. Der er nogen, der kan være i deres hjertens godhed lidt for forsigtige, og det kan være både omkring debridering, det kan være omkring at lægge en god kompression og træffe de rigtige valg. Så der mangler hele tiden viden. Der er en stor udskiftning af medarbejdere, så der er hele tiden mange at skulle oplære og sætte ind i. Folk kan jo komme fra mange baggrunde, lige fra man er fra en eller anden neonatalafdeling eller en hjerteambulatorium eller noget, så kommer man ud i hjemmesygeplejen og skal prøve kræfter med det, og har dermed ikke nødvendigvis en sådan up-to-date viden omkring hverken kompressionsbehandling eller sårbehandling. Samlet set, hvis ikke vi gør det godt nok, og det er jo på alle planer, hvis ikke vi gør det godt nok, så går det ud over vores patienter.
So this is Dorte describing her reality, and David, is it just Dorte?
No, I think Dorte really relates what is happening to many wound care specialists, and I would say North America wide. I think that there's such a high turnover rate these days, and I hear this when talking to colleagues throughout Canada and through some of my colleagues in the US, that they're very stressed out by the very high turnover rates that they are seeing in their role and responsibility that they have as a wound care specialist.
Well, thanks, David. Now, Melody, Dorte talks a lot about having a certain level of wound care knowledge. Can you relate to that?
I for sure relate to Dorte, even though she practices on the other side of the planet from me. We have similar roles and our metrics are the same. Wound care is a large part of my community practice. And certainly I share her concern about the challenge of disseminating best practice wound care education. I'm fortunate in my program, we have a team of CNEs and NSWACs like myself who have literally spent thousands of hours developing educational sessions for our staff and continuing competence. But I'm also acutely aware of the fact that, as Dr. Keast says, it's not common. There's a dearth of information out there, and the need for continuing best practice wound care education is relentless.
Thank you, Melody. So there's something here about lack of education, high turnover of staff, the frustration is really a word that hits me as well. You have the cards in front of you, and we're now going to ask you to vote, because it would be interesting to see where you face, let's say, the most challenges. So if you think your main challenge that you face on your daily basis is lack of education, then you raise the green card. If you think it's the high turnover of staff, then it's the yellow card, or inconsistency of care, it's the red card. And I'm going to challenge you only hold up one card. Only one card. It's a tough one. Yes, I know. I know. Sea of ocean and different colors. Melody, what do you see? What would you say?
I see a whole room full of cheaters holding up multiple cards.
Yes.
Looking at the colors of the cards that you've raised, it does confirm that lack of education is a real problem, as is high staff turnover and inconsistency of care. But in my perspective, two feed the one. It's when we have staff turning over, it increases our need to ensure that we're disseminating best practice. And certainly, this is essential in order to maintain continuity and consistency of care.
David, any reflections?
And I really would have to agree with Melody on this one. The problem really is that they're all interlinked, and it's probably why you all want to hold up all three cards. And it's really tough to try and make a decision which is the greater stressor for you at this particular time. And I think the problem is that they are interlinked. If you don't have the education and you have the high turnover rate, it leads to inconsistency, which really is very difficult for wound care specialists that are in that role of trying to manage these people that are delivering care.
Yeah. Now, David, you were part of the UMA symposium as well, and we did the same exercise in Paris in May. What were your takeaways from that voting?
The takeaway is exactly the same. We had a terrible time trying to get them to hold up only one card. They wanted to hold up all of the cards. Yeah. And as they say, it really speaks to the interlinking of these three things and why there's almost a need to hold up all of those cards, because they are interrelated.
Yeah. Well, thank you very much. Thank you for voting. You'll get one more chance to vote later on as well. So that's why we dare to say that this is a global challenge. And I have the pleasure of working with a lot of healthcare professionals around the world, and they all agree to this. And I think you can relate to this as well as normal life, really, that you face these challenges. Now, we're going to now look at the evidence that supports the wound care pathway. So back in 2019, Coloplast conducted a global study. This was an anthropological study, and it was conducted in France, Germany, UK, and Spain. And the objective with this study was really to understand the everyday life of clinicians managing wounds. Part of the study was also sales reps from Coloplast, because we wanted to see what we could do to support healthcare professionals out in the field. In total, more than 40 deep interviews were completed, and more than 300 surveys were sent out and then analyzed. And not surprisingly, listening and seeing how you vote here today, that there were three themes identified, which became very obvious when we were interviewing these healthcare professionals. The first theme was about the limited training in wound care. This is something you learn on the job. You don't have the formal training. You don't have anything that you can look up. established guidelines are lacking or not being used or being too comprehensive to actually read them. And the third theme was that the treatment decisions are often based more on trial and error and not always evidence-based. So minimizing doubt more than actually thinking of what is the right choice and what should I actually do. So from our perspective in Coloplast, we said, well, if we want to overcome these challenges and support healthcare professionals in their daily practice, we need to focus on access to education and guidance by developing simplified evidence-based guidelines with the target, especially for the non-specialists. So our vision in Coloplast is really about setting the global standard of listening and responding. So before we wanted to do something to actually go for the education and guidance, we wanted to listen first. That's why we, in 2019, in November, started what we call the Consensus Project. We invited 85 wound care specialists from 19 different countries with the objective to discuss about what is optimal chronic wound management. We also had a specific focus during the days to talk about managing the gap, previously known as the dead space between the wound bed and dressing. We wanted to understand if that's important to manage it, how you assess it, and what are the best ways to actually manage the gap. This whole process was also guided by a group of leading wound care experts globally. We had 11 experts participating in this project, and they were kind of supervising us, guiding us what we should do, reviewing and approving the ways forward. And as you can see here on the right, you see Dr. David Keast was also part of this group of experts that supported us in this project. It was a very robust process that we used for the Consensus Project, where we sent out a number of surveys to the Wound Care Days participants in advance. We analyzed the results. We were able to define, let's say, questions and themes that we were to talk about at Wound Care Days. And then we actually held the actual Consensus workshop. This also led to 4 publications afterwards, but I'll come back to that. So what we defined were 8 topics that we wanted to discuss with the 85 wound care specialists. So we wanted to talk about wound assessment, wound bed preparation, managing the gap, effective exudate management, the early signs of infection, managing biofilms, holistic wound management, and patient education. Then all the 85 participants were divided into groups from different nationalities, from different specialties and cultures. And when we were done, we had collected more than 1,000 Post-it notes from the wound care experts with knowledge, their clinical expertise to these different topics that we discussed. So imagine the wealth of knowledge we had on these Post-its. So we set a really high ambitious target as well for this, to say that 80% would have to agree to reach consensus, and no participants should actually disagree with the recommendations. So a very ambitious target. Now, Melody, I know you were a participant from Canada at this Consensus Project, and what were your reflections after being part of it?
Yeah, this Consensus Project was so impressive on so many levels. I felt like it was a real privilege to be able to be a part of such a globally inclusive, important project and gain that exposure to some of our industry's most current research, as well as contribute to ongoing research. I'm compelled to kind of describe the atmosphere. When we arrived to the venue, we were greeted by a long row of flags representing the countries of all of the delegates who were participating in the event. When we entered the Consensus Hall, we literally passed over an illuminated bridge It had the picture of a wound, an infected irregular wound bed on it, and it was massive. We walked over it, literally the threshold of our conversation. And when we entered the hall, we were all around this vast space were giant banners depicting the faces of real clients, reminding us really the real reason why we were there. We were separated into groups, multiple disciplines in each group representing vastly disparate cultures and countries and access to resources. And it was such amazing, thought-provoking discussion and debate. It was just truly memorable.
Thanks, Melody. David, you were part of the consensus project and the expert panel who supervised the project. What were your reflections?
Well, I think many in the audience know I'm kind of a science guy. You know, my training originally was as a chemist, and I taught high school chemistry, but science has been my love. And the thing is that has impressed me about this particular process the most is the absolute rigor of the science that was involved in all of this. Think about it, the surveys that went out to develop the questions, bringing together 8 experts in the field to share their knowledge, to post all their notes, 1,000 post-it notes. Do you know what happened to those post-it notes? They were collected that night, collated, put together, and presented back to the group the following morning, if you can imagine. So I am just really excited about the depth and the breadth of the work and the rigor of the science that went into this.
Thank you, David. Now, we were actually able to reach a number of consensus statements, which was very positive for sure. And I'm just going to highlight 3 of them here. So wound care treatment should primarily focus on providing an optimal healing environment. It's like 100% consensus on this. One of the most important factors in promoting this healing environment is actually managing the gap between the wound bed and dressing. And gap management is really all about exudate management. So when you manage the gap, you manage the exudate, you can reduce the risk of complications such as maceration, infection, and development of biofilm. Some really strong statements on why gap management is important. And when you look at this, David, what would you say is the new evidence here?
Well, many in the audience may remember that in 1999, a group of Canadians got together and worked on wound bed preparation. Excuse me. The first publication ever to deliberately talk about wound bed preparation came from a group of Canadians in the year 2000. In that publication, one of the key things that we said is that we had to manage the dead space in the wound. What we're talking about is a new terminology for this and calling it managing the gap. By managing that dead space in the wound, we reduce the risk of bacterial contamination, we control exudate, and we can improve wound healing. So I think that's the impressive part that goes along with this particular process.
Thank you, David. Now, as I said previously also, that we had thousands Post-its here, and what we were able to do is actually consolidate everything and do a 4-part publication series in Wounds International in 2020. So to the left, you have the Managing the Gap to Promote Healing in Chronic Wounds, which is really describing the whole consensus project and the consensus statement reached. Here is David is the lead author of that one. We also had so much on exudate management, so we did a specific publication on that one. One on preventing and treating infections in wounds, and one on holistic wound management. So all of a sudden, we had 4 publications, a lot of new evidence that we somehow wanted to get out to the wound care community as well. So we use this evidence in combination with the existing evidence to develop this wound care pathway. As I said in the beginning, with focus on providing access to education and guidance and developing these more simplified evidence-based pathways. So here we went away from calling it guidelines, as this is more a mandatory approach, to a pathway. This is something that you're able to follow as you go along. But before we developed the pathway, we again engaged with the listening and responding approach with the wound care community. So during 2020, we sent out surveys again to the Wound Care Days participants and asking what are the requirements if we develop a pathway. And what we learned was it has to be evidence-based and it has to be developed by clinicians for clinicians. Then we asked, we sent out a global survey around the world to actually ask about what should be part of a wound care pathway. What's important from your perspective? And we had almost 2,200 responses on this online survey with ideas and suggestions what should actually be part of this pathway. We then developed a first draft, and then we hosted 8 focus group meetings around the world where they were introduced to the first draft of the pathway. We received feedback, what was good, what needed to be changed, and what could we revise, for example. After that, we had the expert panel reviewing and approving the actual content of the wound care pathway. So we made sure that it was developed by experts with input from more or less all over the world, and that the content was evidence-based. We also then did a ratification process in 7 countries, and I'll come back to those results. So here we are today at Wounds Canada, and we are very pleased to be able to introduce the wound care pathway to you as well. The wound care pathway is a response to the educational need expressed by healthcare professionals around the world, addressing the global challenge of lack of education. It's a step-by-step guide, and we'll walk you through this in a minute, but it's evidence-based all the way through. It's made by clinicians for clinicians, as we learned was kind of one of the cornerstones when developing this. And it's developed with input and feedback from more than 2,200 healthcare professionals. So let's go through the pathway so you can see what steps are included in the pathway. And this is just how it looks. So within the pathway, we have tried to simplify the terminology in the complexity of chronic wound management, but to ensure that we maintain the reader in the document. But if you want to learn more, we have QR codes within the document that you can scan. If you want to learn more, you want to have some more information about it. So we have the QR codes, we have a glossary of terms as well, that you can actually have more as a dictionary you can always come back to. And that's also the purpose of the pathway. We start with a definition of a chronic wound and the most common wound types, and then we have 5 steps. And David, you're going to help us walk us through the different steps. If we start with step 1.
So the key word here is pathway. It's a way forward. It is a way to walk towards wound healing. It's a step-by-step approach with checklists all the way along the line. Simple, straightforward checklists, but with depth behind them. And where do we have to start? We have to start with wound assessment. And I want to remind everyone of my very favorite comment is, please remember that the wound is on a patient, patients in their environment, and we have to assess all 3 things. We can't just look at the wound. We have to look at the patient factors that may impact that wound, and we have to look at the systemic factors. I mean, what are the resources that are available to you to help this person manage this wound? So the first step along the pathway is always assessment. And we need to do clear assessments about the nature of the wound, the kinds of things that all know how you have to assess for a wound itself. You need to look at those patient factors. What are their diseases that they also have? And we need to look at their environment. What is their living condition? Do they live in a poorly hygiened area? I mean, all of these impact what we develop as a care plan pathway.
Yep, so that's step 1. That leads us over to the treatment plan.
Well, the next thing we have to do is develop a treatment plan. And I'm going to relate you back to the wound care prevention and treatment pathway that Wounds Canada uses, because this really integrates with the wound care pathway that also has developed by Wounds Canada. And one of the key things that we need to do here when we're trying to develop that treatment plan is we have to decide where we're going. What on earth is your goal? If you don't know where you're going, you're never going to get there. So consequently, we have to decide, is this wound healable? Is it non-healing? And it's non-healing not because the factors aren't there physiologically to heal the wound, but there may be patient or system factors that get in the way. How do we develop our care plan around those? And finally, we need to really think about who's going to be on our team. I mean, we can't do this alone in many cases, and we need the assistance and help of other disciplines and other people. So who's going to be part of your team? And I'm going to ask Melody to reflect on her approach to managing patient engagement.
Yeah, so in my experience, it doesn't matter what we do as clinicians, as the experts who are responsible for guiding people through their wound care experience, if they're not engaged. And in my perspective, engagement is like, that pot of gold at the end of the rainbow. Everybody wants it, but sometimes we lack the clinical strategies that are really helpful in obtaining it or achieving it. And so I use some very specific strategies in my practice. For example, when I first meet a patient and their family, I provide my credentials and clarify my role, ensuring they know why I'm there. And let them know that I've done my homework. I try to take in as much information as possible that's available to me from the referral information, from electronic medical records, whatever I can to show them that I'm here for them. I've done my homework. I'm taking their care seriously, and this builds trust. It helps lay the foundation for a trusting therapeutic relationship. I educate my clients. It's still shocking to this day how people don't fully understand the cause of their wound in a great majority of cases. So the education that I provide is, whenever possible, as client-centered as possible as well. Some people want the nitty-gritty of pathophysiology, and some people just need the basics. It all depends on their level of understanding. I work with them to formulate a plan. I collaborate and negotiate with them, understanding that sometimes with a healable wound, there are very specific actions that are required for the client to commit to in order to achieve healing. But like Dr. Keast mentioned, these are people in their environment, and we have to be mindful of the fact that they have personal and professional obligations, and not every action is realistic. And so that comes along with setting realistic goals and establishing a plan that they can actually follow through on. Otherwise, you're just sabotaging your work. We then support them by directing appropriate topical therapy, and we are responsible for keeping open lines of communication so that we can assess and reassess without barriers. All of these kind of steps are really laid out quite nicely in the wound care pathway in terms of the direction that we need to go to in order to achieve our goals.
Thank you very much, Melody. So then we move to step 3, how to manage the chronic wound. David.
So now finally we get to focus on the wound. It's something that everybody wants to go to, but they sometimes forget to do the work leading up to it. When we're focusing on the wound itself, there are really 3 key things that we need to do. We need to bride the wound of any non-viable tissue, and we need to therapeutically irrigate that wound, and those are important concepts. Then we have to manage bacterial burden, and we need to be able to assess the bacterial burden and develop means of managing that. And finally, we need to manage the exudate, and we need to control the exudate. We need to find the underlying reasons behind it, and we need to use appropriate choices of our dressings in order to manage that exudate. So here again, we've got a nice straightforward pathway with checklists along the way with QR codes that would refer you back to more deeper knowledge if you need it in those particular areas.
Thank you. So now we've managed the wound, but it's also about how to choose a dressing.
Well, I am related back to what Lisa Ovington said many years ago, and she said really the key thing about dressing choice is form and function. And I would throw in here that we really have to think about the ability of the carer person to actually use the dressing and the ability of the patient to actually wear it. But one of the key issues that we need to think about is if there's dead space in that wound, we need to figure out how to close that gap, how to fill that gap with an appropriate dressing protocol that manages the gap.
Yes, so that's step 4. And then we go to the final step, which is really about monitoring patient and wound progression.
So we get to the final stage. We've done all of these things. We've assessed the patient and their environment. We've developed a care plan. We figured out who's going to work with this. We've addressed bacterial balance in necrotic tissue and exudate control. And we say, wow, we're done and we can just take a rest. And the problem is you're not at the end, you're really at the start of going all the way back through it, because the key thing that we need to do at this point is to monitor what we've done. We need to check in. We need to figure out whether that wound is improving or whether that wound is not improving. And we need to go back and think about those other steps that we took to determine whether we missed something. So monitoring the wound and monitoring the progress and adjusting our care plans as the wound progresses, we need to be doing that on a regular basis. And here again, we have a checklist on that.
So these are the 5 steps within the wound care pathway where you follow. But we've also included a section called when to refer or when to consult, which became very obvious in the development of the wound care pathway. Melody, is it always obvious when to refer?
Yeah, there's no, oh, I'm at this step, time to refer. I have an abbreviated kind of version of the pathway that runs through my professional brain on a ticker tape. It's cause, support, treat, repeat. Cause, if you have correctly identified the cause of a wound and reduced or eliminated it, you're in good shape. Support, if you have supported your healing host, identified all of the potential contributors to non-healing. This might include, for example, nutritional issues, pressure, friction, shear, infection. If you have supported your healing host, moving well along your way, things are looking good. If you have supported best practice wound therapy, so using empiric products or treatments on this wound to support healing, depending on the wound type and goal, and then you reassess, which is the repeat, but it just, rhymes better than reassess. If at any point you find yourself struggling along this cause, support, treat, repeat pathway, that's the time to consult. I don't know what the etiology of this wound is. I think it's this, but it might not be. Or I don't know how to support this healing host. I don't know how to interpret the labs or disseminate which factors might be confounding wound healing in this client's case. That's the time to reassess. Or if you've gone through all of the steps and you still haven't achieved your goal, well, then it's time to review it. Come back to the top or the second or the third and consult. Bring in somebody who can support you in your problem solving and critical thinking to achieve it. So the answer is whenever you need it.
Thanks, Melanie. David, your perspectives to when to refer?
Well, I have to wholeheartedly agree with Melody on this particular issue. And one of the key things that we also have to remember is that we aren't experts in absolutely everything. And so we really need to be self-aware, and we need to be aware when we reach our limits and when we need to seek out help. I mean, it can be something as simple as a venous leg ulcer, which you've done all the right things for, and it's still not healing. And the fact is, if you send it on to somebody who manages to be able to biopsy it, it's been a basal cell carcinoma all along, so that we hadn't actually properly identified the cause. So the real trigger is you've done all the right things and the wound is not progressing in the way that it should. If you've done all the right things, it's time to seek expert advice from someone else who might be able to help you out on that.
Thank you very much. Well, it became very clear for us that it's important to try to increase the critical thinking, not to sit on a chronic wound, to actually reflect, if this is not healing, what should I actually do? And we have then couple of guidelines and recommendations where you should actually seek help and consult, and that it's actually okay to do so as well. All right, voting time. So where do you face the greatest challenge in the patient journey? And you are again only to hold up one card. Is it during the patient and wound assessment where you find it most challenging? Is it when managing the chronic wound? Or is it when consulting with a specialist? When should I do that? So up with the cards and let us see how it looks. I see a lot of colors again.
Yeah.
Melody, your initial reflections?
Yeah, we do see a good distribution of colors. In terms of patient and wound assessment, I think the wound care pathway is a really lovely tool to guide this challenge. I think Dr. Keast and the rest of the clinical experts who developed this have really broken down all of the key elemental pieces of patient and wound assessment in this pathway. In terms of managing the chronic wound, I think once you fall into line and start taking this systematic empiric approach, you will find that the challenges become easier, particularly if you're dealing with an engaged client and family, and your goals of care are and the actions required to achieve them are realistic for their environment. And in terms of consulting with a specialist, this is the one that has a question for me, because I recognize that sometimes it's a matter of availability. So I don't know where y'all practice or how much access you have, but certainly using the QR codes in the pathway will provide you with more information. And again, if it's a matter of you're not sure when to consult versus having access, the point when you should consult, in my opinion, is whenever you have a question regarding what to do next, or if you have not achieved your intended goals. You've done everything that you thought should line up and it's not been realized.
Thank you. David, any reflections?
Well, I think we did see quite a distribution of colors out there, and I agree with Melody that there may be multiple factors impacting what we're doing here. Some of you may have difficulty with the assessment piece because of the lack of resources or the lack of engagement of the patient in this particular part. Some of you may have trouble with the management process because, again, environment, lack of resources. It really will depend on your particular environment, which is your major challenge. But if it is your major challenge, you now know where you've got a place to work, a place to try and improve the care and the outcomes for your patients. And certainly we do have to be prepared to say every last one of us needs at some point to look for the assistance of somebody else to help us get the maximum outcome.
Yeah. Thank you to you both. All right. So we're now going to consider the opportunities with the wound care pathway and how it can actually be used in practice. And we are again going to listen to Dorte, who is the wound care specialist in Denmark. She has been introduced to the wound care pathway, and she's been working locally in adapting it as well to the recommendations within Danish Wound Healing Society. And this is what she sees as the opportunities.
Jeg tror, at det bliver et rigtig godt redskab med sådan en GPS. Fordi den er ret sådan systematisk og struktureret. Og det tror jeg kan være en rigtig god hjælp for mange medarbejdere. Og det kan jo også være en god hjælp, når man står som sårsygeplejerske og skal tage udgangspunkt i at skal have oplært folk. Patienterne vil jo ikke direkte vide, at vi har noget, der hedder en GPS. Men patienterne vil jo altid nyde godt af, at de møder en kompetent medarbejder. Og det er jo det hele drejer sig om. Det er, jo dygtigere vi er, jo bedre hjælper vi patienten. Længere er den jo ikke. Man kan ikke hjælpe sig af en, der sådan er halvrolig, eller man skal have et vist vidensniveau. Så kan vi hjælpe patienterne.
So this is what Dorte says. Melody, would you agree?
Oh, Dorta, I've never met the woman, but I truly feel like she's my sister from another mister. I agree with her completely. I agree with her on the struggle with disseminating evidence-informed education, and that this pathway is a really lovely resource for clinicians in need. I think about the wound care guideline that was developed in my home province, and it fits comfortably in a 2.5 to 3 inch binder. And I mean, a guideline is really only as good as the time you have to read it and apply it. Dr. Keast and the other authors of this pathway were very specific in how they developed it. And I see it as a compass that's kind of helping lead the way, but he can elaborate more perhaps.
Go ahead, David.
Well, I really do see this as a clinical decision support tool. There's a lot of evidence out there. There are clinical practice guidelines out there. My joke always about a clinical practice guideline, because I hold up one that has 200 pages and I say, put that in your back pocket and carry it around with you so that you know what you're doing. What we really needed was an approach, that a checklist approach where you could go through the steps that you needed to do to follow the pathway, but then look for the available information on the past, in the past and other things. And I think the other thing that I would say is that this integrates so wonderfully with the educational material that Wounds Canada has developed, because it provides the depth to this pathway. So when you look at their best practice recommendations, this tool then supports the implementation of those best practice recommendations. And I just can't emphasize the importance of checklists. And my son he loves to fly. And he's recently purchased a rather ancient and heritage airplane. And I've had the privilege of going up with him. But the key thing is that every time he takes that airplane up, out comes the book, and he goes through it step by step by step by step and a checklist, so that my trip with him in the airplane is safe. So you can go through this pathway step by step through your checklist, so that you and your patient are in a safe way and achieve your goal of wound healing.
Thank you very much, David. I like what you described it, Melody, as the compass. And you might have heard when Dorte spoke, she was saying GPS. So they call it the wound GPS in Denmark, as a guidance, taking you forward on your path to your goals. And that's healing, of course. All right, I said we did a ratification as well, and we did this spring last year. So we asked 96 healthcare professionals in 7 different countries. And if we look at the results, I mean, 98% agrees that this document is built on strong evidence by experts in wound care. When followed, it may actually help to reduce the burden of chronic wounds. And 95% agree by following these recommendations, it will actually help the non-specialists going from dressing changers more into wound healers. So we, in Coloplast, we believe this document can make a difference. And I would say it's really obvious that healthcare professionals think so as well. If you want to read more about the wound care pathway, we have the publication of the process and development of the pathway, again in Wounds International, on the left side here. And then on the right side, we have a meeting report from the UMA symposium we had in Paris in May, where we address again the global challenge of lack of education and high turnover of staff. I'm very happy to say that the wound care pathway now is available in a number of languages. We have it in French, Spanish, English, German, Chinese, and Danish. I also learned that we have it now in Belgium and Italian as well, and more countries to follow to make sure that we can share the wound care pathway with, with the global wound care community. Let's see how we're doing here on time. Yeah, we have 5 minutes. Good. So this concludes the symposium. I'd like to leave you with the theme of Wounds Canada today, which is about from knowledge to action. And I think what we are bringing here with the wound care pathway is evidence-based knowledge that you can actually take into action and use in your clinical practice and with your colleagues. Now we have 5 minutes then. So does anyone have any questions for David or Melody?
Data on wound care knowledge for healthcare workers in the community, in particular in the Southwest region. We have a pre-survey. We've got some online wound care modules and a pre-survey that when you log on, you have to do. And if you take a look at that, you can see that 69% of nurses who had worked for over 6 years in the community doing wound care had little to no wound care education. It's over 50% of patients that are in home and community care are on service for wound care, and the need for standardized wound care education is just such so crucial. So it's very timely in terms of, and I'm wondering, how are you going to, because the challenge always is in home and community care in particular, you have sometimes nurses that are seeing up to 20 patients a day. That one nurse who talked about seeing, 5 to 10 patients would be a privilege in our current healthcare space. So they're seeing upwards of 20 patients. So how do you see, because from an education perspective, how do we engage? How do we roll this out? And how do we get this information out to our frontline nurses? I'll just tell you one sort of like alarming, because, and if you take a look at the poster, it says that over 60% of nurses who did the pre-education survey thought that the way to heal a wound was with dressings and antibiotics, that would heal a wound. Yeah. So that's the level of knowledge that you're dealing with. And really the whole point was that wound care is a postgraduate expertise. It's not something that anyone comes out of any education with that knowledge, and it's postgraduate. So how do we disseminate this knowledge to our healthcare professionals? Thank you for the question. I think both David and Melody has made some reflections on how this can be done.
If I may, thank you for validating what our commercial partner in Coloplast has already done extensive work to try to present. When I started off earlier in my contribution to this conversation, I identified that lack of evidence-based best practice wound education wastes time, it wastes product and resources, and it has devastating outcomes. Conversely, once we improve clinicians' education, it improves efficiencies. We see clients on our caseloads for less time. We see optimized healing outcomes. We see faster rates of contraction. And so distributing helpful resources like the wound care pathway, it's literally putting information, best practice knowledge at the clinician's fingertips. And once they become more and more familiar with the pathway, I anticipate you'll have a better result, less need to have people on our caseloads for prolonged periods of time with suboptimal outcomes.
David? Yeah, I think what I would agree with Melody is that I think that the pathway provides you with a tool to assist in educating people in terms of appropriate wound care education. I mean, there's lots of information out there, and sometimes people get overwhelmed with it. And part of the goal here was to provide with a straightforward pathway with a checklist along the way that's something that people can follow. and where they can go to get the more deeper education and information because the resources are sitting behind it. But it's really helping people to have an approach, a way to think about what they're doing when they face a person with a wound. So it's really that approach to doing it and a straightforward pathway that's the way to do it.
We have 1 minute, which means we have one more question.
Comment and a question. The comment is, you know, a lot of the issues that we're having around wound care is exactly what the previous question poser had said, is that you can have knowledge, but if you don't have that, if you don't have the ability to practice that knowledge under someone who can say you're going down the right path or you're going down a rabbit hole. So we don't have that mentorship piece. And wound care right now belongs to nobody. It doesn't belong to medicine. It doesn't belong to nursing. And it shouldn't belong to one particular, and even in medicine, it doesn't belong to surgery or dermatology or family medicine. So it almost needs to be its own specialty. And we've been talking about multidisciplinary, which is incredibly important. So my question, so that's my comment. My question is really practical. If you're saying to someone, don't sit on a stalled wound, how long should a person practice on a wound before saying, this is stalled, I need to find advice, I need to go ask someone?
So in my opinion, this is a really complex question that you asked in very few words. When we talk about recalcitrant wounds, we need to acknowledge there are a plethora of factors that might be contributory. So if you go back to my cause, support, treat, repeat, anytime you're not achieving your desired goal, that's when you would refer back to your resource, whether that resource is a person or a printed pathway, or frankly, a 300-page guideline that you can't fit in your back pocket. That's the time to go back and look. There is no specific wait a week, wait 2 weeks. There is no canned answer.
Yeah, and that's the unfortunate part. And I can tell you that's been the debate for 20 years.
Yeah.
You know, I mean, that's just the problem. When do you do this? And there's no hard and fast rule that says, well, it should be in 2 weeks or it should be in 4 weeks, because we have to remember that every patient is an individual with their individual needs and wants, individual environments, individual supports. And we have to try and take all of those things into account. And I mean, you can certainly say, well, it's not getting any better, and let's go back and think about it and let's try this. But one of the things that I worry about when I see it is micromanaging. And I think really, if you're going to institute something, you at least have to give it a couple of weeks to see whether the body's going to respond to it, unless you have some urgent problem that develops on it. But micromanaging is a major problem. So we really don't want to do that. But also we don't want to avoid assessing and reassessing the wound and making sure that we are on the right path and thinking about where it needs to go. And I would hope that within people's individual agencies, people would work as a group and they would talk amongst themselves and seek support from each other. And when you've exhausted the support that you've got, or that it's becoming quite urgent, then you try and seek some care. And I will freely admit that unfortunately in the current environment, you can make that referral, but boy, is the system ever backed up and people are having a terrible time accessing those consults in a reasonable time. And I'm as guilty as anyone else of being in that area.
Thanks, David. That would be then the final comment. Thank you, the audience, for listening, and big thank you to Melody and David as well. Thank you.